So I think the one thing that's become abundantly clear from this conference is sequencing is going to be routine at initial diagnosis within a very short period of time. The second thing is because of feedback loops and parallel pathways, what you're going to see is combination therapies in everyone. And WIN is the model of this because it brings together triple therapies at a minimum. So WIN is unique in being the global organization which covers this. And the third thing, as Leroy Hood elegantly pointed out, he started the P4 initiative in 2012. Sequencing is going to be routine at birth, and instead of focus more on disease, it is going to be focused on maintaining wellness. So the whole of the sequencing of the genome will utterly transform medicine. So if you just think of a metastatic disease patient at this point in time, it costs approximately $1 million per patient to treat those. If you refocused all of that money and concentrated on, for cancer, initial aggressive treatment, and longer term on completely maintaining wellness, those should be our foci. Put all the money early in diagnosis, in prevention, and you will avoid those huge costs at the end of life. So I think this whole business of organoids is fascinating. We've been trying to do in vitro sensitivity assays ourselves in our own lab and are very frustrated. What Rob showed is that these organoids are feasible. They reflect the complete clonal populations of each of the tumor. So it looks fantastic for drug sensitivity. Still has to be tested out. One of the key issues at the moment is cost. It's costing around 10,000 euros per organoid. But they seem to have got the time frame down perfectly now. They can grow these up in 4 weeks and then do drug sensitivity testing. So in reality, you could probably feed back to a patient in 5 or 6 weeks and offer them therapies which have been proven to work on their own tumors ex vivo. So yeah, you've hit on the nail exactly. So if you think you could do a whole genome sequence in the patient itself, you could actually do some proteomics, work out all of the networks that are regulating that tumor. That could be used for matching your drugs in a drug screening model in the organoids. So you would have a complete picture of the sequencing from the tumor plus in vitro, ex vivo sensitivity testing, and combine those, and you have a truly individualized patient therapy. So the PDXs were fascinating in that they had reflected, at least in their colon models, they'd reflected about 10 different drivers amongst their PDX organoids. And so what I had asked from the podium is whether you could actually take those 10 or 11 genomic drivers in the colorectal population and then run a basket or umbrella trial and run drugs individualized to those. The only limitation on this, of course, is it would have to be combinations of drugs. So you would have to in each of those PDXs identify at least a couple of drivers so as to give maximal gain to the patient. So the Shiva trial had the fault, forgive me, of taper and match with matching single drugs to the dominant driver. And that is fantastic for farmers. It's less good for the patient because of these whole feedback pathways that always keep the cancer alive. The cancer will do anything to evolve to stay alive. So all of these single agent trials, whether it's going to be Shiva, taper, NCI match, will not have dramatic results. One will only have dramatic results from the WIN motto that you need triple therapies to basically drive the tumor. So the future basket trials will have to be focused on N of 1, where you give triple combos to each individual patient. We have sequenced 500 patients in the recent past. We have usually treated these with double or triple therapies. At this moment, we have a 60% RECIST response rate. In our fourth-line breast cancer patients, we unbelievably have a 57% RECIST response rate. And in our neoadjuvant triple negatives, where we are adding targeted therapies onto standard therapy, we have at this moment a 79% pathological complete response rate. So they are small numbers, it's early days, our drug matching is not perfect, but this gives great hope when you apply triple therapies matched to the genomic drivers.